Okay, so I'll start.
Please do. Go ahead.
Okay, thank you. Good evening, everyone, and thank you so much for joining us this evening. I'm a member, my name is Marion Burton. I'm a member of the Peterborough Health Coalition, and we're very excited to have this opportunity to host a town hall meeting in regards to the privatization of our healthcare services, specifically out of hospitals at this point in time. Just a little bit of background. The Peterborough Health Coalition has been in existence since about the early 2000s, I believe. Peterborough is very much a working class community. I myself worked at our local hospital for 47 years. I'm quite proud of that. And I remember back in the 80s, NAFTA was, coming into play federally. Factories were closing. There was massive layoffs of good paying manufacturing jobs. And I remember thinking, oh, how fortunate am I that I chose a job in healthcare in the public sector. I'm safe. Anyways, then along came the 90s and healthcare cuts started to happen. Hospital closures, reduction of hospital beds. Then we got into, we're going to build a new hospital here in Peterborough, and many in our community, a lot of retired workers, specifically out of General Electric, lobbied our local hospital board quite profoundly to insist that it be funded as a publicly funded build. And they were successful, and we're very grateful for that. It was the last hospital in Ontario built as fully publicly funded. P3 hospitals, unfortunately, are the norm, and they tend to run into billions of dollars in overruns, costing us a lot in our as taxpayers. We watched privatization of long-term care. We watched our home care delivery being privatized, and the reduction in quality of services went down the drain. This week in the paper, we have the Home Care Ontario CEE wanting to stabilize and begging the government to move faster in sending an additional $880 million into the sector. So we know that these private processes have caused great harm into the delivery of healthcare in all fronts. And now we're looking at the privatization of hospital services into private clinics, and we know what will happen should that occur to the care in our hospitals. We have several speakers this evening, and I would like to introduce them to you. Our first speaker is Sarah LaBelle, is chair of the Hospital Professionals Division for the Ontario Public Service Employees Union, and she's a medical laboratory working out of Lake Ridge Hospital, just down the road. She has worked for 23 years in healthcare and has been fighting to defend public health care right from the start. And so thank you, Sarah, for being here with us this evening. If you please take it away.
Thanks, Marianne, and thank you to all of you for taking the time to join the Health Coalition tonight to talk about privatization of healthcare and why it's so important for us to work together to defend our public healthcare system and to defend surgeries, privatization of surgeries and diagnostics. I've been a medical laboratory technologist for 23 years, and lab testing has been one of the things that the private sector has very much been enamored and want to have their fingers on for a long time. It is an over $5 billion industry across Canada, and there is a lot of profits to be made from private testing. We saw that in COVID during the pandemic and COVID testing, where every single hospital across the province ramped up capacity to provide 75,000 COVID tests every single day. And that was done without any more staff. And it was done by predominantly the public sector. It was public hospitals that were spending $2 to $3 million in some cases a month to do that COVID testing, and doing it in the public interest. Contact tracing and tracking made sense. It allowed us to know where there were outbreaks, where we needed to put extra measures in place, where we needed to enforce masking, and to keep each other safe and protected. So imagine the private sector having control over $2 to $3 million a month in extra testing that, in the public interest. It would not happen. And in fact, during COVID testing, we saw private clinics charging people for access to COVID tests. They were charging for access to COVID tests, and the people that were paying to get access were people who wanted to travel. Those that had the luxury of the income or the ability to travel, while people could not get access to COVID testing in order to check to see if they were okay to visit their loved ones in a long-term care home. So that's really what the cost of privatization of healthcare is. It's the healthy and the wealthy getting access to the services, to testing. And when it comes to medical radiation technology, having access to X-ray, CTs, and MRIs because they want to jump the queue, not because they've been triaged and prioritized in a public hospital based on need. When we see patients in our public hospitals, we triage based on the most serious case has to be seen first. They get prioritized for surgeries. That all happens in a public system that is built for the public interest. It has nothing to do with the size of your wallet or how healthy you are. The private sector poaches workers from the public sector. We have seen it across every single jurisdiction that has allowed private clinics to flourish. They have poached the workers that we all know in every single sector of the economy. Everybody is short-staffed, and in healthcare, very much so. The people that provide all of those tests, that do the surgeries, respiratory therapists, anesthesia assistants, perfusionists that do all of the monitoring, all of the testing that's done, the x-rays that are done in order to monitor when you're going through your surgery, all of the post-op care, that gets lost if you allow that to go to the private sector. People will leave and the wait times will go up in the public sector for surgeries that are higher need, higher care. Make no mistake, they are not interested in the complex surgeries like cancers. They are not interested in the complex comorbidity patients that may require heavier care, longer stays in a hospital. They have no interest. They will pick. They will skim the cream. They want the easy tests. They want the easy surgeries. They want the patients that will have better outcomes in order to skew their numbers and make it look like private is better and more efficient. Well, of course you're more efficient if you're not dealing with the same kind of patients. 100%. We know this is already happening. They take beds away in the public hospital system, because if one of their patients goes south in a private clinic and they require heavier care or emergency care, that will come from the public sector. It will tie up paramedics and ambulances from taking people from a private clinic then to a public hospital in order to deal with an emergency. We have to cross-match units of blood for every single surgery that occurs. We, depending on what type of surgery, our lab people are cross-matching several units of blood, anywhere from 4 to 10, depending on the complexity. We have a shortage of blood products. Who is monitoring and keeping control of what blood products are coming in and out in a private system? There are more questions than answers about this vision of the, provincial government, and it will take away valuable resources and wait times will go up. People will pay out of pocket, poorer patient outcomes proven time and time again, and it will cost more ultimately. So the best thing that we can do is defend our public healthcare system, defend our surgeries and our diagnostics in our public hospitals, because they are very efficient. We proved that in the pandemic. We did so much with shoestring budgets and no money from the government. So why would we not reinvest that money back into the public sector?
Thank you, Sarah. Thank you very much. Great information, great background. Our second speaker tonight is Kelly Henwood. Kelly is a member of the Ontario Nurses Association, works locally at the Peterborough Regional Health Centre, and today organized a fabulous rally outside of PRHC, if anybody was able to make it over, to support our nurses at the hospital. Kelly, please take some time to address the crowd. Thank you.
Good evening, everybody. Thank you very much for inviting me to speak to you all tonight. It was quite a chilly day today, picketing, but it was also very heartwarming as well. So if you were there, I thank you very, very much for coming and supporting us. Not something that nurses normally do, so it was a bit of a challenge, but it turned out very, very well, I think. I have been a nurse for 43 years. Worked in Toronto for a bit, but have lived and worked in Peterborough for the last 23 years. Originally, I came to Peterborough as an ICU nurse, then spent quite a long time working in emergency, and now I work in the recovery room. And I also do an awful lot of own a business as well. I'm the grievance chair for our Peterborough Regional Health Centre. So talking about the state of nursing right now, and as Sarah before me was talking about what would happen with privatization, you know, you can kind of see the same thing happening in nursing. The Peterborough Regional Health Centre currently has 900 RN jobs, of which just over 200 are vacant. There's recruiting that's ongoing, and it seems that as they recruit more nurses, the few that they come in, more go out the door. It's been very difficult lately to recruit nurses and to keep them there. Sometimes they come in, they get their courses, they get a bit of education and orientation, and then they move on to something else. So our units tend to work very short every single shift, and our patient care is suffering. There are times that our units in the hospital have no RNs at all working on them. Sometimes they will pull from another unit to make them short to put an RN on the unit, and sometimes there's just no RN to work there at all. Most of the time, our patients don't know that. We manage to hide it quite well, and we work quite hard to make sure that we try and meet their needs. And I guess probably the worst place to know about the nursing shortage is in our emergency department. Our wait times in the emergency department have gone up dramatically. You can be there 8, 10, 12, 16 hours, I've even heard of in some places. And it's very disheartening, and to go along with the fact that of those 200 jobs I was talking about vacant, 25, our emergency department is missing 25% of their RN staff. So it's quite distressing. There are times when we close zones in our emergency department. We have to move our staff around to be in some of the zones, the more critical zones, and not every nurse can work in those critical zones. You have to have a certain amount of skills and experience to work in there. So sometimes our zones have to be closed down. Sometimes the zones are closed because we have to do hallway nursing. And I know when we first built this hospital back in 2008, they promised no hallway nursing, but the reality is that it happens every single day. And it's going to be worse. I mean, if they open privatization clinics, you know, where are they going to get the nurses from? You know, the nurses are sitting in the hospital system for the most part, and that's where they will come from to go to the clinics because, you know, why wouldn't you? No weekends, no night shifts, easy work. Because as Sarah said, they'll take the cream of the surgeries and the easy stuff and move them into there. So it's very, very disheartening to hear about all of this. I really only have a few years left of my nursing career before retirement. And, you know, I'm just very sad about the way it's all turning out. Currently, our hospital has put out incentives for us to pick up shifts on weekends for overtime. The response over the Christmas holidays was actually quite good, but there's only so much overtime our staff can do. They're burning out. A lot of them haven't had vacations. They get their vacations denied constantly. Sometimes you get a day here and there, but to get a week off is a big challenge in a lot of our inpatient units. We're tired, we're burned out. And, you know, I don't know how we turn all this around. It's going to be quite a big challenge. But ONA is choosing to start with our campaign of better staff, better wages, better care for the patients. And hopefully through a new collective agreement that we're negotiating right now with the Ontario Hospital Association, we can gain some ground on this. And ONA sees this kind of as the first step in trying to bring members back into nursing that have left. We need to bring our youth into our nursing schools and get them taught and get them trained and out into the workforce to take over for all of us that want to retire. So really that's about it. That's really about my speech for nursing and the Peterborough Regional Health Center. Hopefully our contract comes up with a fair collective agreement and they're able to show us some respect. Thank you all for inviting me tonight.
Thank you, Kelly, very much. It is a very sad state to know that this is what our workers are experiencing. Our third speaker, Shayna McLaughlin. Now, Shayna is a primary nurse practitioner and is a project lead for a proposed Ashburnham Family Health nurse practitioner-led clinic. Primary care is lacking in our community, as many people know, as doctors retire. And so there's some different initiatives that are being put forward. And so Shayna has agreed to come and just give us some information about other possibilities of primary care to service the community. Shayna.
Yeah, thanks, Marian, and thanks, Sarah and Kelly, for touching on some of the hospital level problems and issues that are ongoing. I guess I think to start, just in terms of privatization of healthcare and how that affects areas like primary care, which, as we mentioned, we're already so short in providers locally and nationally. It's a problem as well. So we're seeing privatization of things that should be primary care pop up all over the place already too. So I've heard of patients that have ADHD that are having that managed by paying a $30 a month fee for a membership, and they're being followed online virtually and receiving care for that. I think we've all heard of the Maple program and the app where you can receive primary care if you don't have a doctor through there. And then just in CBC, I think that was yesterday, you can pay $30 a month for access to a nurse practitioner for your children. So in Toronto during the winter months when when kids were so sick, the physicians at a pediatric clinic weren't able to keep up. And so they hired a nurse practitioner that they pay based on charging patients a $30 a month fee. So I think when it comes to primary care, when you are working in primary care, you already see the disparities in terms of access, and people with, you know, more material, you know, capabilities or social determinants of health are a little bit more robust. They're better at advocating for themselves and accessing that healthcare system. And when you further privatize primary healthcare, that disparity is only going to get worse and to grow. So that's where the public systems, like things like community health centers, nurse practitioner-led clinics, that really focus on those marginalized populations and making sure to try to, you know, gain some ground in terms of health equity. So that being said, that's what myself and a team of nurse practitioners are working locally for, another nurse practitioner-led clinic. And I think that that's when the government says, you know, this public system isn't working, we need solutions. There's a lot of solutions that are being proposed that are public, that are not being, you know, jumped on. We're jumping through several hoops and having several meetings for something that is so obviously needed. We're at around 15,000 unattached patients as of the end of April, when 2 more family physicians retire, who each spent 18 months personally looking for somebody to take over their practice. So like the access is obvious, or the need is obvious. And we are ready to go. We have nurse practitioners, we have nurses, medical secretaries, a social worker, a child and youth worker, who are all lined up. We have space ready to go. And we've had this proposal into the government at the end of July. And not till just this past month have we gotten a little bit of traction in terms of meetings with the Ministry of Health and Ontario Health. But for, you know, to say that, you know, to give up hope in the public system and to throw your hands up and look for other solutions when there's people here wanting to give the care, I think that's where it's, you know, a little bit frustrating to hear. So, yeah, I mean, I think that's just the unfortunate nature of the government's priorities right now. But there are people here that still believe in public health care, and nurse practitioners, I think, are certainly the advocates for that, having that holistic and whole patient perspective from their nursing care, to be able to provide that to people and provide it to people that need it most. I think
Great.
that's all I have to add. Thanks, Marion.
Thank you very much, Shana. I'm going to invite Natalie Mahara now. After that, if there's questions and other dialogue that people wish to contribute to, we'll open it up for others to have a chance to speak or ask. Natalie is the Executive Director of the Ontario Health Coalition, and she has been active for many years fighting the big fight to keep our public healthcare system alive and functioning the way it should. We're very grateful to all the work she's done over the years, and we're very glad to have you here this evening, Natalie. Go ahead.
Thank you so much, Marion, and thank you to all of the amazing women on this panel for your comments. I'll try and be fairly quick. I just wanted to tell you what the Ford government is doing. Right? I mean, at its core, it is very simple, and it sounds almost conspiratorial, but it really, I mean, there is no other way to read it now. It's the old formula: create a crisis, or very least worsen the crisis, blame it on the public system, and then use that as an excuse to privatize, which has been the goal all along. And that is exactly what we're seeing. You know, the staffing crisis that Kelly and Sarah describe among health professionals, nurses, and others, care workers in the public hospitals, also exists in long-term care and in home care, is by a million miles, you know, by such a long distance, the worst that we have ever seen. It is truly unprecedented. It actually is impossible to exaggerate how bad the situation is now in Ontario. Recently, I did an interview with the investigative reporting team with the Toronto Star. They were looking at the number of emergency department closures, and this is kind of the canary in the mine shaft. They found that there have been 158 emergency department closures across Ontario between February of last year and February of this year. 10 would have been unheard of. We have never seen a situation in which local hospitals are closing down emergency departments because they don't have enough staff to run them, closing down birthing units and maternity beds because they don't have enough staff for them, closing down ICUs, as happened in Bowmanville, because they don't have enough staff to run them. I mean, these are the most critical, urgent services that we have. Doubling up in ICUs, in pediatric ICUs, doubling up in adult ICUs because they don't have enough staff to maintain safe staff to patient ratios. I mean, this is unheard of. Not running MRIs at the night shift because they don't have enough staff to run the machines, even though the wait lists are massive. You would think that in this kind of scenario, you would see the provincial government put their shoulder to the wheel. You would think that they would do everything possible to get staff back, staff who've retired out, who've burnt out and left, who've left literally in the thousands, and yet they haven't done that. In fact, in the most recent budget, the last year's budget for Ontario, the provincial government underspent its healthcare budget by almost $1 billion, $800 million underspent. At the same time, they kept wage caps on the wages for the health professionals and the nurses and so on in public hospitals and public and not-for-profit long-term care and so on throughout. These are the people who have literally risked their lives for us during the pandemic and in all of their careers, subject to wage caps, just as thousands of them are leaving because of the conditions that you heard, because their vacations have been denied, because they have been deferred for so long, because the workloads have become so crushing, so unsafe and impossible, because every time they're off, they get called in to cover overtime and so on. And they know if they say no, that they're letting their colleagues down and their colleagues have to work short. It's just an endless amount of stress, and it's not possible for them to continue to do it. You would think that we'd see Doug Ford on TV in commercials asking the recently retired staff to come back, providing a portal to shunt them into hospitals that will take them, paying their licensing fees to bring them back in the short term while we train more to come in. You'd think that they would be providing guarantees of some control over scheduling, a light at the end of the tunnel, anything. None of that, zero, has happened. And instead, what they did actually, while they were underspending on public health care, they doubled the funding in the last quarter of the last financial year to the private for-profit clinics. Then they bumped it up again in the summer, and then they announced a big increase in January. And this is what they announced. They said they're moving forward with plans to, quote, significantly, in their words, expand privatization of surgeries and diagnostics to for-profit hospitals and clinics. They'll be bringing in new legislation. Actually, they just brought it in on Monday, and they're speeding it through the legislature. They may have, I don't know, I didn't catch it yet. They may have finished second reading debate today. They may pass second reading on Monday. They could pass it as fast as next week. Because they changed the rules of the legislature in order to be able to drive through legislation very quickly, of course, to stifle public opposition. The government has already called for bids for 3 new private day hospitals. They call them clinics, but I mean, let's face it, they're day hospitals to do 14,000 cataract surgeries initially, as well as diagnostics. They're giving $18 million in new funding on top of the 2 earlier expansions of funding to existing private clinics to cover care for, quote, thousands of patients. The announcement included more than 49,000 hours of MRI and CT scans, 4,800 cataract surgeries, 9,000 ophthalmic surgeries, that's eye surgeries, 1,000 gynecological surgeries, 2,845 plastic surgeries, and so on. I'm giving you these numbers so you get a sense of the scale of the privatization that we're talking about. They're also expanding the number of private clinics and intend to further expand their volumes, as well as expanding the types of surgeries that they privatize. They plan to have private for-profit hip and knee surgeries up and running by 2024. So our assessment of this, and I should have said in the list of what they could have done otherwise, Shayna's point about the fact that there are nurse practitioners all over Ontario. If we wanted to stabilize primary care, why not provide them a way to bill in, OHIP? Why not approve these nurse practitioner-led clinics, which provide amazing care? It's progressive, it's public, it operates in the public interest, as opposed to, of course, privatizing more and more and more of our healthcare system. So our assessment of this announcement is that it's very serious indeed. Obviously, they lied in the lead into the election. We held 20 press conferences across the province. We warned that they were going to privatize the hospitals. They sent out a ministry spokesperson after us to the media in each of those communities to tell them that that was categorically false, that they were not expanding the private clinics and would not be expanding the private clinics and hospitals. At the same time as they would actually behind the scenes doubled the funding to them, therefore expanded them, and now have continued. 2 months after the election, they announced their plans to go forward with privatizing the hospital surgeries and diagnostics. So what does this mean? Well, in places like Peterborough and other communities, what the Ford government said, what Ford said, Doug Ford, the premier, in a media scrum after the announcement was, it was their government's assessment that 50% of the surgeries were the easy ones, and thus the ones that they are looking to privatize. Well, when you look at that, and of course, there will be private businesses lined up to take over those volumes. The hospital system is tens of billions of dollars that they would want to make profit from, of course. And it will go very quickly once it starts to go. There's no question. And they will take, of course, the profitable parts of the public hospitals, as everyone has described. And so when we look at places like Peterborough or the Kawartha Lakes or Haliburton and Northumberland, most of the surgical volumes that you have are the ones that are the most at risk for being privatized under this system. It would gut the local hospitals. And this isn't about creating local private for-profit clinics. They need to do volumes that guarantee them sufficient profits. They tend to locate in areas of the country where there are high income neighborhoods where they can upsell extra stuff to make more profit. Their business model is to bill OHIP and to bill the patient on top as much as possible to maximize their profits. And this is not speculation. We called every private clinic in the country twice. We called once in 2006 and 2007 and put out a big report on it. We caught the majority of the private clinics that existed at that time extra billing patients. So we phoned, we said, we need a shoulder surgery. How much will it cost? How fast can I get it? I want to jump the queue, etc. And we caught the majority of them violating the Canada Health Act, which prohibits extra billing patients and charging when people are in medical need. You cannot charge for a medically needed surgery or a diagnostic test. That's illegal in Canada. That's what we won when we won public Medicare in this country. You cannot charge for a medically necessary hospital or physician service, and that should cover nurse practitioners as well. And they should be fully covered under the public health system because of the services that they provide. But that happens routinely in the private clinics. We called all the private clinics in Ontario twice more. Again, we caught the majority of them extra billing patients. And then we phoned all the private clinics across Canada. We worked with the Globe and Mail. And Riley, do you mind just putting the link into the Globe and Mail story? I think you just Google Globe and Mail private clinics double billing and it comes up. And we got a five-part front page series in the Globe and Mail. They used our database and our transcripts from the calls with all the private clinics, in which we again caught the majority of the private clinics, not a small number, the majority of them, extra billing patients and charging patients for medically needed services. And the prices were ludicrous and remain, actually, they've gotten even worse. So for cataract surgery, what we're talking about in a private clinic, they routinely charge $2,000 an eye for cataract surgery. Under OHIP, and it's a 7-minute surgery. I mean, under OHIP, they're doing very well. They're among the top billers of all doctors that there are. Many of them bill $1 million a year or more to OHIP. And the cost is $550 per surgery. So they're charging patients 4 times the cost illegally for a surgery that is covered in our taxes that no patient should ever be billed for. And in addition, they'll tell patients routinely that they need an extra eye measurement test, which they don't. The OHIP covered test does everything you need. It's medically unnecessary. But if you have 1,000 patients and you charge all of them $200 extra for an eye measurement test, that's $200,000 extra that you make that year. If you charge $2,000 for your cataract surgery, it's $2 million extra that you make that year. And that is exactly what's happening. They'll routinely tell people try and upsell extra lenses and all kinds of add-ons. In the hip and shoulder surgery clinics, we found that they were billing patients 10 times the cost of the surgery in the public system. In the MRI clinics, the starting cost is routinely $1,000 in the private clinics. When we ramp up our MRIs in the public hospitals to do more to clear the backlogs, we pay $280 to $350 on average for the MRI. In the private clinics, they start at $1,000. Add contrast, it's more. Add body parts, it's more than that. I mean, the prices are outrageous. So they take staff and funding from the public hospitals. They leave the heavier care, more complex patients, the people with heart arrhythmias and COPD, the people with diabetes who are overweight, who might have higher risk on the operating room table. They leave them behind with less money and less staff to provide for to the public hospitals. They take the profitable cases, they increase costs, they don't decrease costs because they bill OHIP and they bill on top, and they bill facility fees and physician fees to the public system as well. And they maximize their profits that way. There are serious safety issues in the private clinics that in the meta-analyses, and these are undeniable, these are studies of all of the existing studies that look at literally millions of patients in thousands of hospitals. They have found in the United States, for example, that the for-profit hospitals have higher death rates than the not-for-profit and the public hospitals. Why? Because they skimp on staffing. The for-profit hemodialysis clinics have higher death rates than the not-for-profit ones. Why? Because they push the blood through the machines faster in order to get the patients in and out faster. They skimp on the amount that they clean the blood. They replace registered staff, trained staff with untrained staff in order to cut costs and maximize their profits. That is the business model of for-profit healthcare, very much like we've seen in for-profit long-term care, where the way that they run their long-term care homes is to have less staffing, poorer pay, poorer working conditions, and less staff than the public and the not-for-profit homes, and therefore higher death rates, higher rates of hospitalization, higher rates of all kinds of avoidable injuries and harm to patients. Mike Harris, when he was in office, and many of you will remember, privatized home care. And it's been a disaster ever since. They privatized the majority of long-term care. And we all saw what happened through the pandemic in the long-term care homes. Now Doug Ford has come for our hospitals, and we don't want to let him do it. We want to find a way to fight back, to stop the privatization of our hospitals. And we know that the vast majority of the public does not want to see their services in their local hospitals cut and centralized and privatized to for-profit corporations. We know this. So we have to make it visible. We have to make it something that the government can't ignore. And our idea was to hold a referendum. We did this before, actually, on the P3 hospitals. And Riley's going to show just a 3-minute video in just a minute about what it looks like. But it worked. We actually rolled back the privatization. We didn't entirely stop them, but we rolled back the privatization very, very massively. None of the services in the new P3 hospitals are privatized as a result of referendums that we held in 8 towns, in which we got about, I think it was 198,000 votes 98% of which, of course, were against the P3 privatization of their hospitals. That was at a time when the media would not tell the story about what the government was doing. In this case, everyone knows. It's all over the news. Everyone knows the government is doing it. So we have a much bigger range of publicity about it. And for weeks now, we have been signing up literally 1,000 people a week to help to do this, to stop them. Our goal now is to get 1 million votes at the end of May, 1 million votes to stop the privatization of our hospitals, to hold on the street votes Friday, May 26th and Saturday, May 27th. That's the weekend after the long weekend in May. So that's outside coffee shops and drugstores and busy corner stores and things like that, you know, at the Legion, outside the LCBO on Friday night, etc., and try and get as many votes as possible from people walking in busy areas of the city and the communities around. In the 2 weeks leading into that, we would want to do workplace votes. Every workplace we can. Unionized workplaces through their unions. Could we get the shop stewards to walk around and collect ballots? Could we do ballot boxes at shift change as people are on the way from the workplace to the parking lot or what have you? In not-for-profits, could we get as many votes as possible in the not-for-profit agencies and the senior centers and so on? Can we get the non-unionized workplaces, the local businesses, to have votes in their workplaces as well? That would be the last 2 to 3 weeks of May, collect the workplace votes. And in the and then we do online voting as well in order to provide access for people. And the goal would be that we would count the votes. The workplace votes could come in earlier for the schools and the community colleges. We could do their votes at the end of March before they go into exams, or the very beginning of April. And then they would count for your community's total when the total community vote comes in. And then we would announce the votes on the Tuesday. So that was the 27th is the Saturday. So that's the 30th of May. And then deliver as many of the ballots as we physically can to the legislature. That and then the legislature ends on June the 1st. So so that's what we're asking. Will people support this? Can we make it happen in your communities as well? And then of course in the lead in we'll have all kinds of press conferences and social media and information, a leaflet that can go door to door, all kinds of public education and information going out there so people understand the issues and understand what they're voting on. I'll just end with this, if it's okay. In Alberta, when the same time the Meg Harris government was in Ontario, you know, the private clinics date back to the 1990s, the big budget cuts of the 1990s, they would never really have existed except for that period in time. And in, you know, Ontario, the Mike Harris government was cutting and privatizing. And in Alberta, they had a similar government under Ralph Klein. And he exploded the Calgary Hospital. It was this big macho thing. They were going to bring this revolution in healthcare and so on. And they brought in a piece of legislation like Ontario has just introduced to bring in private clinics. And people lined up down the highways to fill the galleries of the legislature. I remember seeing it on TV. People were hanging from the banisters in the legislature to stop this legislation. Of course, they had a majority and they passed it, but the public rose up and they actually stopped the private clinics. They, the Friends of Medicare, our sister group in Alberta, collected the receipts from all the patients that have been charged in the private clinics for their MRIs and CTs. We held protests across the country. They made a massive complaint to the federal government and to the provincial government. And ultimately, Ralph Klein, arch privateer, was forced to pay back every patient that had paid for a medically necessary MRI and CT scan in his province, and they rolled them back into the public hospitals under his government. It was amazing. And he said, healthcare is the electric third rail of Canadian politics. And I always loved, that was not a compliment, by the way, but I always loved that. It was, you know, on the railway, you've got the tracks that the train goes down, and then you've got the middle track and it carries the electricity, and you're not supposed to touch it or you'll get electrocuted. And I thought, that's what we're doing. We're electrifying the third rail. Let's make them afraid to touch our public health care. It's not theirs to take away. Thank you.
Well, that was inspiring. I think everyone would agree. And now we know that it can be done. And so how do we go about pulling this off? Because we have to, we just absolutely have to do this. First, though, is if there's any questions anyone might have, if you're not familiar with Zoom, and if you look down along the bottom of your screen, you'll see reactions. If you click on reactions, you will see raise your hand, as Riley has shown in the example on his screen. So if you can please indicate your desire to ask a question, we'll do that for maybe we can just take 2 or 3, and then we can move into how can we organize this? Are people willing to step forward to support organizing this type of great action in our community? So we have Linda.
Hello there, it's Linda from Northumberland. Listen, I was wondering, Kelly, I think that was her name, the RN from the Peterborough Hospital.
Yes, yeah.
Yeah, so when I was in Northumberland Hills Hospital more recently, as an outpatient, I heard them using code black. And code black was about not having enough services in emergency or beds. That's what I was told when I asked, because I thought, code black, what's that? Like, I was quite concerned. Anyways, does that happen in the Peterborough Hospital? That's what I was wondering if you've, and like, I don't remember ever hearing code black being called in my whole life prior to the last few months. So I'm just wondering about that.
So not all the hospitals run on the same kind of codes. For us, a code black is a bomb threat. But I mean, we run short-staffed every single shift, every single day. They put out on our shift. It's called Vocantis. It's a massive email goes out to like to all the nursing, all the RNs or all the RPNs or whatever, we get them every single day. We know that there is they're short-staffed every single shift, so we've never actually called a code black. I know I'm sorry, but I don't even know what our code is off the top of our heads for that. I know
Isn't
there
it
are a
code
few
gridlock at your place? Or, sorry.
No, it's a color. Oh, code gray. Lisa Barker just popped that in. It's code gray. And there are a few times when we should have called it, but our administration refused to call it. So now, I mean, we work short, we take the people that'll pick up. You know, if you want to come in for 4 hours or whatever, they'll take whatever they can get. And then they just shuffle the staff around. You know, a unit may be fully staffed tonight, so they're gonna rob 1 or 2 of those nurses and send them somewhere else. And sometimes it's, you know, you take your mental health nurses who probably haven't done any kind of hands-on acute medical care on a patient, and stick them with a patient assignment on the medical floor and expect them to, you know, give meds and do treatments that, you know, they don't have the experience doing. So it would be nice if our hospital would actually call that, but they've never called it.
Okay, thanks, Kelly. Sarah, you have your hand up, and my apologies. Riley was going to show the referendum 2-minute out of Kingston, their process that they went through, but go ahead, Sarah.
I was just going to say a code black is a bomb threat that's universal across hospitals in Ontario, but hospitals have come up with other codes to indicate infrastructure or staffing issues on the closures and short staffing. You know, Natalie mentioned the amount of times emergency departments have been closed because of short staffing, but would be alarming is the number of times that they are remaining open while not having enough people to staff that emergency department. So Campbellford Hospital, which is just down, the next community over, a few communities over, is routinely running with paramedics helping triage patients because they don't have enough nurses in their emergency department. So that takes paramedics out of service from, Northumberland County. They're now having to deal with helping to triage patients. And so it's just a complete log jam of, staff all across the board, and it impacts more than just hospitals, right? Like for every time a patient is stuck in emergency department waiting, it's because not enough nurses, maybe there isn't enough doctors, maybe there's not enough people to do the testing, and the paramedics are caught up in the whole thing, and it's just an inefficient use of resources when a very, very easy fix to that is to have enough staff in our public hospitals. And it's a very, very easy fix. And this government doesn't want to address that problem. They'd rather just give the money to private clinics.
Thank you, Sarah. Riley, I'm going to go back to you and ask for you to show the short video on the referendum process.
Great, thank you, Marion. So I just thought it would be really helpful to show this video so that you have an idea of what it looks like when it's put into place, as well as the kind of volunteers that we're going to need to make it happen. It's really quick.
This looks very much like an election campaign, except it's not. It's a plebiscite vote that's actually citizen-run, not government-run. It's put together by the Ontario Health Coalition, asking citizens if they want a public or private hospital.
Well, the drivers have extra ballots, so if they need more, like if they've run out in their trucks, then I will let them know you guys have some extra.
The phone's been nonstop. People are interested. They want to learn more. They've been very supportive of the campaign. We've had very little people coming in upset about what we're doing.
Well, we're holding a community-wide plebiscite, which is a community-wide vote, like a referendum, only it's organized by a citizens group, by the Kingston Health Coalition, about the future of the new hospital in Kingston, whether it's going to be a public, not-for-profit hospital, or whether it'll be built as a P3, privatized P3 hospital with 30-year-long contracts with a private for-profit multinational consortium.
Some people wonder how this affects healthcare. They say, well, the healthcare system remains public because nurses and doctors will be paid by the government. But the model of the P3 hospital is a step in quite a dangerous direction.
Some of the more conservative members of council have tried to argue that we shouldn't have any role in it as municipal councillors because it's a provincial issue.
So we're very concerned in the city of Kingston about where is the money from our property taxpayers going, and it turns out that it's going to fund a consortium that over time will make 12% on their invested money. So that 12% is, part of that 12% is coming from our property taxpayers.
It's been really positive. It's actually really cool. People are pretty excited, especially when they hear that there's 180 other volunteers out there on the ground doing this as well. It's just such an incredible feeling of solidarity. Everybody, even though they've been out there in the cold for an 8-hour day, they have no problem doing it. They're having fun and having a great time.
It's been very hectic, super hectic. We had 3 volunteers here for most of the day, and we barely had a chance to have a drink of coffee, and we're right here in Tim Hortons, so that just goes to tell you how busy we've been.
All the businesses have just been so warming and welcome to allow us to be able to set up these poles. It's been a great commitment by the businesses here in Kingston.
It was a huge victory, and you talk to people on the street, everybody knows what's happening. It's now become a public issue, and it wasn't 2 months ago. Nobody even knew we were getting a new hospital. So we've elevated the debate and the public sort of discussion and the democracy around this healthcare policy to a level which is phenomenal. That's the value in a sense of validating that whole discussion, all that work that was done. And then as the next step forward, we're going to be able to say to the government and the politicians, you know, this community really cares. We want a public healthcare system.
Great. Yeah, awesome video. Doesn't that make it look exciting and simple, and the solidarity in the effort? Go ahead, Natalie. Natalie. Is she gone? Natalie did have a CTV interview to leave, and maybe she was saying goodbye. Is that what she was doing? I don't see her name here. What do you think, Riley?
I think she did just need to step off as well.
Okay. Okay. So, what do people think? Is this something you would be willing to give a bit of your time to support an action like this? We know it can be done. And so, you know, I think it would be a very exciting process to engage within our community, because I haven't heard anybody say what a great idea that they're privatizing these services. Have you? We would like to take some, you know, get some feedback, people who might be interested in helping out. Riley, can I hand this over to you to move from here?
So as you guys saw in the video, it's going to take a lot of boots on the ground in our communities to get this up and running. We've got a great group here, and this is, I think, probably my 15th or 16th town hall across Ontario I've been on, and we've seen a huge uptake in our members and our email lists and people getting involved that we haven't seen, new people getting involved. So we really need to capitalize on that and get people organized. The next thing that we need to do is we need to set up regional in-person meetings. And these wouldn't be like this town hall. We all know the issues now. It's to get this up and running. And we're going to need people to really step up and do that. So what we need to do is get people who are willing to step up and volunteer if they want to become sort of like a part of a committee to run a portion of it. So if you are willing to volunteer, please write your email address or your name in the chat and maybe what city you're in so that we can sort of connect you guys according to where you are. If you have a particular interest in whether it's going door to door with our leaflets or even making stories on social media and putting them out there that way, if you're able to, you know, go drink some more wine at the LCBO and get some empty wine boxes to make ballot boxes with. There's something that we can all do to help us out here. So if you have a particular interest, just write it in the chat. It's going to take us all. And even if you can just print off, you know, 50 leaflets on your printer and donate them, every little bit is going to help. And that's really what we need to do now. And I see a lot of people volunteering already in the chat. So if you don't know how to use the chat, you can just toggle or put your cursor over the toolbar at the bottom, and the chat is the little speech button there. And we're going to be saving the chat too, and we'll be getting in contact with you afterwards. Well, that's amazing.
Wonderful. Oh, I'm so thrilled. Thank you, everyone. This will be a significant undertaking, absolutely. But I know that we can do it. And oh my goodness, it's amazing. So fortunately, Riley is our technical support, and we'll have know your contact information that we can get back in touch. I do see a hand up with Sarah McNeely.
Hi, yes, thank you. Thank you for organizing this and for the wonderful panelists who spoke. My question is regarding the online portion of this campaign. I understand the physical balloting and the scheduling in terms of workplace and then general public. Can you please elaborate on the plans for the online portion?
You mean a time frame, or like what is the online going to look like, or?
Yeah, just a general time frame and yeah, just a little more of how that would work. I'm not sure if you need physical copies or.
Yeah, so this isn't going to be like an official referendum that would be done through the legislature. Those take way too long, and there's so many roadblocks where they can block us with that. So we are going to be able to do it online. There's going to be like a place to like testify that you have not voted anywhere else. People would need to put in their postal code. There'll also be the security measures, like maybe the CAPTCHA to like make sure bots are not spamming it to skew the results or anything like that. And we would be looking at getting that done earlier than obviously the weekend there.
May I follow up on that, Riley?
Yeah.
Would that be potentially then existing petition software that sort of has those checks and balances built into it?
We haven't figured it out yet. If anyone has any suggestions about that or knows of software that's good for that, we are all ears.
Okay.
Thank you.
Thanks very much, Sarah. Good questions. Peter.
Hello, yes, Peter Watch, QP retiree, as you can see in the moniker, and I just want to thank all the speakers for great presentations. It's been a great session, and I like the idea of the referendum precisely because it's about mobilization, and I think that's what we need to do. We need to mobilize people. People are really, really angry about this, and when people are angry, it's not about just phoning politicians or petitions. That's fine. Well, petitions are actually better. But actually getting people out doing stuff, and people want to do stuff. This is the one of the crowning achievements of the Canadian working classes was pointed out on Tuesday at the Halliburton meeting. So it's crucial that we as working people defend public health care. Today we went to a wonderful picket. I thought it was cold. It was at PRHC, organized by ONA, and I like the idea that ONA, that OPSU, that CUPE, and that SCIU, all the unions are leading, because we need to make sure that that link is really, really close with the union members who are inside the hospitals. And I think we need to know, maybe Sarah, you can talk about OPSU's plans. I don't know, maybe I should know about CUPE's plans. I will find out. I'm a retiree, so I'm not completely in the loop here. But in terms of just continuing to be on the streets, because I think that time has come. And another tactic that I thought was very good, used in December, was the Save the Greenbelt folks did in Peterborough. They did about 3 different pickets on the side of Lansdowne Avenue. They had over 100 people out, and a lot of people saw them. And what this can do, these pickets, either at PRHC or on the street, can build up a little profile. We can use the media for that, and we can build up a little excitement, because I don't think we should run into the referendum without a little excitement and more people seeing that we're starting to mobilize, we're starting to move, much like the education workers, where they campaigned for months before they built their picket lines. And we saw in Peterborough, we saw hundreds of people out because our members knew, retirees like myself knew where to go, OPSU members, teachers, everybody knew where to go. And it was successful because of that. And it pushed the union leadership to push the Ford government. And I think that's the model. So I like what we're doing, and I think we have to stay mobilized. Thank you very much, sisters and brothers.
Okay, thanks very much, Peter. Any other questions or comments? I love all the chat. I'm trying to follow along here, but I'm sure Riley is going to be able to capture all of that. I see Jennifer has her hand up.
Hi, thank you very much for the invite into this group. This is my first meeting. I too prioritize my health as very important and am very much a supporter of the public healthcare system. I'm aware of the P3 and how bad they can be, having been a correctional officer when they tried the experiment in the prison system. Currently, I'm on WSIB with OPSU, and I am glad to see Sarah here. She has been a representative of OPSU for a number of years, well respected, so it's glad to see OPSU's present. And I hope moving forward, OPSU starts to answer the phones and things like that, because during the pandemic, for people like me who were unvaccinated, etc., it has been a nightmare. And I really do hope moving forward, if we want to have a good, strong public sector, you guys really need to start focusing on the Ministry of Labor and start ensuring your health and safety committees within your work site are as strong as possible. Any of these ideas you guys have had about surgeries, staffing, these can be done through recommendations. Staffing numbers, I would have tended to put through the Management Executive Relation Committee, although you can phrase them in such a way that you could put the recommendation in at the Health and Safety Committee level. And then you guys would be getting responses back every 21 days to the things you want. So if you thought you could do a surgery in this room, your coworkers could come up with an idea, your committee can submit it, and within 21 days by law, you have to get a response back from the employer. And it can't just be a yes or no. Like if it's a no, they have to give you prescribed reasons why they're denying it, right? Then there would be more accountability for the money as well. I won't waste any more time of yours, and I think one thing too, if you want to keep the private the same level as the public, you have to ensure that we're doing inspections inside these work sites, right? Because all work sites need to be kept the same at the same standard. I think the Ford government hates the Ministry of Labor, has completely ignored it. And that's why we've been at this divide right now, first with COVID, with people having different ideas. If there was the Ministry of Labor involved, we would have all had transparent information. And I think now it's just moving on to targeting the healthcare sector even more. But thank you for your time.
Oh, thanks very much, Jennifer. Appreciate that. Anything else? I'll just turn it back to you, Riley, for next steps.
So I just wanted to say thank you. We've had so many people volunteer in the chat. It's been amazing. So our next step is we're going to be holding a regional meeting for organizing. So you're all on the list. We're going to be sending out a follow-up email tomorrow for those who weren't able to make it tonight, and you'll see ways that you can get involved. There's some things that you guys can do right now, which is if you go to ontariohealthcoalition.ca, halfway down our page, it says become a Medicare defender. We're really trying to get that number up as high as we can so that Ford sees it and knows that he needs to back off. That's just one site. We also have a mere sign up on the Council of Canadians as well. So there's more numbers than just, I think we're up to a little over 4,000 now there. The Council of Canadians has a few thousand on theirs as well. So we really need to get that number up there and going. I believe the Council of Canadians, if you haven't signed up for them, I think they're planning to be sending out sort of like a guided script for sending letters to the editors so you can write into your local newspapers about privatization. There's things that you can do like that to help get the word out. What we really need to be doing is having our conversations with our neighbors, with our friends, with our family right now. We're seeing even on, like, for example, the Facebook post for this event tonight, in the comments, we're seeing bots spamming about the pro-privatization meeting. We're seeing people putting out misinformation. So what we really need to be doing is clarifying that with the arguments that were made tonight and taking on these, clearing up these misinformation and really not letting their message get out there any further. So that is the next step there. Does anyone have any questions? Oh, I see Sarah.
I'm sorry. Thank you, Riley. One last question. Just in terms of, we're going to meet again, but in the meantime, while we're thinking, I understand in terms of resources, person power, boots on the ground seems really important, but I wonder, do you have plans to do any fundraising? Like, are there other resources that we can be thinking about ways to secure as well?
That's a good question. We run completely off of donations, and a large amount of that is from private donors. So if anyone does have the capacity to ask someone to donate or to donate themselves, you can find that on our website as well. I'll put the link in the chat. But regardless of funding, we are obviously going to go forward with this, and we're going to do what we can do. It's a huge help, and we're super appreciative if anyone is able to give it or give and support us there as well.
Can I add in a little bit there?
Yeah, go ahead, Natalie.
Yeah, so the plan is, I mean, obviously, in different towns, we need to know from you kind of what is going to work. When we did this before, if there's like, is there still a weekly paper that's delivered to every household in
Yeah, the
Peterborough?
Peterborough this week.
Okay, and so in some communities, those papers are well read. Or there's a penny saver that goes to every household and people actually look at those. So in one of those, if we can afford it, we would like to put an insert that has basic information and a list of all of the voting stations in town, right? The dates of the votes, list of all the voting stations. If we could afford it, we would do that. Or buy some postal walks if we need to. Obviously, we want to leaflet the entire community. So people going door to door, if you're willing to, it's great exercise and it will be spring. And then also in every community group, every possible way, you know, get out the leaflets with an insert in it with your local voting station. So we'll need to print those. I think, would like to supplement with hired staff to help in as many communities as possible. So if communities are keen on doing it and really want to do a big job of the referendum, then we will try to find the funds. We'll try to make sure that we have the funds or raise the funds to ensure that we can provide some paid staff for like that month-long, you know, lead in. So sort of April into the end of May and through till we release the vote counts and things. So there are some like paid resources that we should be able to do. It all, of course, as Riley says, depends on how much we can raise, and we'll start putting out asks and things, and people are donating. So I think we should be able to do that. And in those communities, if the feeling is people really want to do it and really want to do a big job, then we'll put extra money into supporting in that area, because then obviously we've got the infrastructure and the capacity to really make it happen as much as possible there. I think that's how we'll do it. And if anyone has any other ideas about things like that, you know, or better ideas, we're so open. I mean, we're just trying to make it as big and effective as possible.
Okay, super. Great. Well, it's just been a great hour and a bit. I think we all have a general idea as to what we're looking to accomplish. We're looking to accomplish defeat of the Ford government, for sure, and to maintain our public healthcare system. If they can do it in Alberta, you darn well bet we can do it in Ontario. So anything else before we sign off? I just want to say thank you so much to Sarah and Kelly and Shayna and Natalie for speaking, and to all of you for your great questions, your great support, and for giving us this time this evening. It's been fabulous. I'm feeling quite exuberant right now, so that's good.
Did you ask for volunteers? Sorry, just to.
Yeah, it's in the chat.
Okay, so people are going to identify themselves, and particularly if you're in a town that isn't Peterborough, like doesn't have a local coalition anywhere in the region, if you can identify where you are, if you're willing to help, that would be great. Sorry to double up.
Yeah, no,
And Marion
that's...
and the Peterborough Health Coalition, we love you. Thank you so much.
You're welcome. You're welcome. Okay, I guess that's it then. Good night, everyone. Thank you so much. We'll be in touch soon. Thanks, O'Reilly. I didn't say thank you to you. I'm so